Dear students, welcome to today's learning session. During the course of this presentation, we are going to learn mainly about various aspects of allergic rhinitis and touch briefly upon the other forms of rhinitis. This is Dr. Binu Raju George, Associate Professor in the Department of ENT. Have you ever thought that a mundane disease like rhinitis would have a definition? Well, it has. Rhinitis is defined clinically as having two or more symptoms of anterior or posterior rhinorrhea, sneezing, nasal blockage, and slash or itching of the nose during 2 or more consecutive days for more than 1 hour on most days. What about rhinosinusitis then? As you know, the mucosal lining of the nose and paranasal sinuses are contiguous, and hence it is quite common for both to be affected together. So if we use rhinosinusitis as the term, the patient should have symptoms like hyposmia, anosmia, headache, and facial pain also. The classification now. Broadly speaking, rhinitis can be classified into allergic, infectious, and other types of rhinitis. It is for the infectious type that we generally use the term rhinosinusitis, while for the allergic and other varieties, we prefer the term rhinitis. Allergic rhinitis was earlier classified as seasonal and perennial allergic rhinitis, depending on whether the symptoms are present during a particular season or throughout the whole year. A recent classification has suggested that the terms seasonal and perennial should be abandoned in favor of intermittent and persistent. We will talk about the classification of allergic rhinitis in a later slide. Infectious rhinosinusitis is classified into acute and chronic forms depending on the duration of the disease. Now, the other forms of rhinitis are classified into atrophic, drug-induced, emotional, food-induced, gastroesophageal reflux-related, hormonal, idiopathic. There's a form called NARIS, non-allergic rhinitis with eosinophilia syndrome, and occupational. Let us go into the detail of the different forms of other forms of rhinitis now. So this is atrophic rhinitis. This is a condition that occurs predominantly in women and is characterized by progressive atrophy of the nasal mucosa and underlying bone of the turbinates. This leads to formation of thick crust in the nose, leaving a constant foul smell in the nose. The drug-induced type, several commonly employed medications such as aspirin, other NSAIDs, beta blockers, angiotensin-converting enzyme inhibitors, oral contraceptive pills, and nasal topical decongestants like oxymetazoline or silometazoline may induce symptoms of rhinitis when they are administered topically or systemically. One specific condition to be kept in mind is rhinitis medicamentosa, that is, excessive use of topical decongestants may lead to hyperreactivity and hypertrophy of the mucosa, leading to nasal block. Emotional factors like stress can lead to the patient developing symptoms of rhinitis. Food-induced rhinitis. Hot and spicy foods can lead to watery rhinorrhea, and this is termed as gustatory rhinitis. Alcoholic beverages are thought to induce symptoms of nasal obstruction due to vasodilatation. Gastroesophageal reflux is also postulated to play a role in some patients with rhinitis. Hormonal rhinitis is often associated with pregnancy. This happens due to the combined effect of estrogen and progesterone, which cause vascular engorgement and increase the expression of histamine receptors in the nasal epithelium. The idiopathic form of rhinitis is also called vasomotor rhinitis. Another name in which it is known is non-allergic, non-infectious perennial rhinitis, and is NANIPER as it is called. It is characterized primarily by symptoms of nasal block, rhinorrhea, and sneezing, and this condition is associated with an imbalance between the sympathetic and parasympathetic nervous systems. Non-allergic rhinitis with eosinophilia syndrome is characterized by the presence of more than 20% eosinophils in the nasal smears of patients. Occupational rhinitis, as the term implies, is rhinitis caused by exposure to airborne agents present in the workplace. Exposure to flour in bakery workers, laboratory animal workers, and exposure to latex rubber are examples. Here is an easy way to remember the different types of rhinitis, which are included in the other forms of rhinitis category. You might have noticed that I have arranged them in alphabetical order. A stands for atrophic rhinitis. There is no B and C. Then we have D, the drug-induced, E, emotional, F, food, G, gastroesophageal reflux, H, hormonal, I, idiopathic. Then we don't have J, K, L, and M. Then we have NARIS, and then the occupational type of rhinitis. The symptoms that I described earlier can be as a result of a host of other factors too. Hence, the differential diagnosis will include nasal polyps, mechanical factors like a deviated nasal septum or hypertrophic turbinates, tumors, granulomatous diseases, and CSF rhinorrhea are other conditions which can mimic the symptoms of rhinitis. Now we have come to our main topic of the day, that's allergic rhinitis. We will discuss about the classification, the allergens, and their mechanism of allergy, the comorbidities associated with allergic rhinitis, the clinical features, and management. The risk factors for allergic rhinitis can broadly be classified into genetic factors and environmental factors. There is a definite genetic predisposition for allergic rhinitis. Studies have shown that a child with history of allergic rhinitis in both parents has a 50% chance of developing the disease, while the incidence comes down to 30% if either of the parents or one sibling is affected with the disease. Environmental factors also play a role in allergic rhinitis, and the incidence has definitely gone up in the past 40 years, especially in developed countries. Increased exposure to allergens, pollutants, and irritants, lifestyle changes, and dietary modification responsible for reduction in protective nutrients and increase in stress. All these have contributed to this rise. So this is the classification which has been proposed by ARIA, which stands for Allergic Rhinitis and its impact on asthma. ARIA is a WHO initiative. They have laid down certain guidelines for the classification of allergic rhinitis. We had touched briefly upon the new classification earlier. And here, the classification goes like this. If the patient has symptoms for less than 4 days per week or less than 4 weeks, use the term intermittent. The symptoms are present for more than 4 days per week and more than 4 weeks, we call it persistent. Both the conditions, that is, more than 4 days per week and more than 4 weeks, should be satisfied to call the disease persistent. Each of these two forms of allergic rhinitis can be classified into mild and moderate to severe, depending on the severity of the disease. Thus, by mild allergic rhinitis, we mean that the patient has got normal sleep, normal daily activities, normal work and school, and does not have any troublesome symptoms. If the patient has any one or more of these symptoms, the disease becomes moderate to severe. That is, if the patient has abnormal sleep, the patient feels tired and sleepy on waking up, and he'll not feel fresh during the course of the day. If his daily activities are impaired, sporting and leisure activities, all these are impaired. If there are problems caused at work or school, that is, effectiveness at school and work are reduced, there is impaired classroom performance, learning and cognitive functions of the child are disturbed, and if the patient's got troublesome symptoms, then we include the patient under the category of moderate to severe allergic rhinitis. So just remember that there are four things, 4 points to be taken into account: sleep, daily activities, school or work, and the presence of troublesome symptoms. Thus, the different types of allergic rhinitis are mild, intermittent, mild, persistent, moderate to severe intermittent, and moderate to severe persistent. Thus, the mildest form of allergic rhinitis is a mild intermittent form, whereas the most severe form would be the moderate to severe persistent allergic rhinitis. Here is a list of the most common aeroallergens: pollen, fungi or mold, animal dander, house dust mite, pets, and insects. The major allergenic pollen include Parthenium or Kongini as it is called in Malayalam, Cassia fistula, which is Konna, and this is resinous, that is resinous commonness or the castor bean. These are the different fungi which are aeroallergenic. This is the Alternaria conidia, and this is the Aspergillus fumigatus, the conidiophore from culture. Alternaria and the Aspergillus are the most common fungi which act as allergens responsible for severe allergic rhinitis. House dust mite, animal dander from pets, and cockroaches also can trigger an allergic reaction in the host. By the term animal dander, we mean the tiny flecks of skin which are shed by cats, dogs, other pets, and birds, which can result in an allergy. From the different allergens, let us proceed to the mechanism of allergy or the pathophysiology behind the allergic reaction. There are four phases for this mechanism. The first phase is the phase of sensitization. The second phase is the subsequent exposure to the allergen and the early phase response. Third one is the late phase response, and the fourth is systemic activation. Let us see what happens during the first two phases. So upon the exposure to the allergen, that is the allergen that enters the nasal cavity in atopic individuals, is captured by the antigen presenting cell. So this is the antigen presenting cell. So after capturing, these APC, that is antigen presenting cells, process the antigen and present it to the resting T lymphocytes in the local lymph nodes. These T lymphocytes mature mainly into the T helper 2 cells at the site of allergic response, and they secrete the cytokines IL-4, IL-5, IL-13, and IL-12. The T helper 2 cells also activate the B lymphocytes, which proliferate, and then they differentiate into plasma cells. The plasma cells produce IgE antibody, which is taken up by the mast cells, and they selectively occupy the receptor in the mast cell. Thus, the mast cells are now primed or sensitized. So, this is the phase of sensitization. The next phase, that is on subsequent exposure to the allergen, let us see what happens. This is the early phase response. On subsequent exposure to the antigen, the mast cells with the IgE, they bind to the antigen. Degranulation of the mast cells results. The inflammatory mediators are released, resulting in allergic symptoms. These mediators include the preformed mediators like histamine and proteases, and the newly generated mediators like cystinyl leukotrienes like C4, prostaglandins like PGD2, bradykinins, and interleukins. And these mediators together they cause sneezing and nasal discharge, nasal block, as well as itching in the nose and other areas. So we have just gone through the first two phases. Let us see what happens later on. The late phase immune response is the third stage. It uh, occurs in approximately half of the exposed patients. And this phase involves the ingress of eosinophils, basophils, mast cells, neutrophils, T lymphocytes into the local tissues, and all these contribute to the inflammatory response which presents as nasal obstruction and hyperreactivity. During the next stage of systemic activation, antigen stimulation in the nose or lung causes the release of eosinophil precursors from the bone marrow which circulate to both these sites. So just before we go to the comorbidities, we sum up the pathophysiology. Remember that there are four phases. First phase of sensitization, second one an early phase response, late phase response seen only in 50% of the individuals, and the fourth is a phase of systemic activation. Let's look at the comorbidities now. Inadequately treated or untreated allergic rhinitis can lead to complications. These complications become comorbidities, that is, conditions which exist along with allergic rhinitis. They include asthma, sinusitis, otitis media, sleep disorders, lower respiratory tract infections, and dental malocclusion. Rhinitis is a definite risk factor for the development of subsequent asthma. Strong evidence suggests that allergic rhinitis, the effective treatment of which definitely helps to reduce asthma, and this has given rise to the concept of a unified allergic airway, a single entity with a common epidemiology and pathophysiology. Atopy and atopic march. Atopy, as you know, is a term used to denote the process of IgE production in response to exposure to an allergen. Atopy can result in asthma, allergic rhinitis, or food allergy. Atopic march is a quaint term which refers to a sequential development of allergic diseases. This often starts in infancy with atopic eczema, then the development of allergic rhinitis, and finally allergic asthma. So this is the atopic march. The clinical features now. What are the symptoms of allergic rhinitis? The first and the most important and the most distressing symptom for the patient is sneezing. So this can range from a few sneezes to even up to 100 episodes per day. The sneezing might be so severe that the patient feels embarrassed in public. Patients often complain of persistent watery nasal discharge and nasal obstruction. Another frequent symptom is itching in the nose, eyes, ears, throat, and palate. Other symptoms include reduced perception of smell, headache, postnasal drip, cough, eye symptoms like red eyes, swelling around the eyes, and increased tear secretions. And if the symptoms are severe and affect the patient's sleep, the patient might feel sleepy and tired during daytime. The signs of allergic rhinitis vary depending on the severity of the disease and the presence of coexisting conditions. In mild allergic rhinitis, the signs are few and one will have to make a diagnosis from the symptoms and the anterior rhinoscopy findings alone. You might be able to get some clues from the facial expression and changes in the eyes or the external appearance of the nose. An examination of the nasal cavity, you might find pale swollen mucosa and clear watery nasal discharge in the nasal cavity. The inferior turbinates might appear to be bluish and boggy. When there is allergic rhinitis, the inferior turbinates they undergo hypertrophy, causing nasal obstruction. To relieve the nasal block and the associated symptoms of allergy, the patient will produce a lot of facial and nasal movements. This is the typical facial grimace seen in patients with severe allergic rhinitis. Severe nasal block and mouth breathing can also result in the typical mouth open and dull looking facies. So, this typical facies uh, need not only be present in adenoids, but if the obstruction is really severe and the patient is not able to breathe through the nose, then you might find this in allergic rhinitis also. There might be signs in the eyes too. On examination, you might find conjunctival congestion or a cobblestone appearance of the conjunctiva. In some patients, there might be bluish or purplish discoloration with shiny looking skin below the eyes. This is due to venous stasis, and these patients are called allergic shiners. You might also find small radiating skin folds from the medial canthus. This might ensue in such patients, and these lines are called Denny Morgan lines. Patients, especially children, might try to clear and thus open the nose by frequently rubbing the nose with their palms or fingers. This action resembles a salute, and hence the term allergic salute is applied to this gesture. This frequent rubbing produces a horizontal crease just above the tip of the nose, and this sign is called Darier's sign. So this appearance, the allergic salute, and this is the Darier's sign, which is seen sometimes, not in all patients, in a few patients of allergic rhinitis, especially if the disease is quite severe. Persistent mouth breathing might result in malocclusion, a high arched palate, and a receding chin in patients with severe disease. We have learned about the atopic march earlier and how atopic asthma and dermatitis can develop in patients with allergic rhinitis. So we have to look for signs of skin or lung involvement in such patients. Before we proceed to the management of allergic rhinitis, let us sum up what we have learned till now. We have learned about the different types of rhinitis, the risk factors for allergic rhinitis, its classification, the different types of allergens, the pathophysiology or the mechanism behind the allergy, and the clinical features. Let's now see how these patients can be managed. So management includes investigations and the treatment. Only a few patients with allergic rhinitis require confirmatory diagnostic testing. The patient's history and physical examination are sufficient to make the diagnosis in most cases. If appropriate medical therapy is instituted and it controls the patient's symptoms, then no further workup or testing is required. So practically speaking, about 95% or even more than that of patients who come to the ENT OPD, they do not require further testing, even skin tests or their RAS estimation or even nasal allergen challenge are not done in the majority of patients. However, if medical therapy fails or if it does not resolve the patient's complaints completely, or again, the patient wishes to implement certain allergen avoidance measures and wants guidance as to what to avoid, or again, if the patient is taken up for immunotherapy, these tests have to be done. So we have to confirm the type of allergy, the type of allergen before we proceed in such patients. Investigations can broadly be classified into in vivo allergic tests, in vitro allergic tests, and the nasal allergen challenge. In vivo allergic tests include the skin prick test or SPT, the intradermal test or IDT. In vitro allergic tests include the total Ig estimation and the specific Ig estimation, a method of which is called the RAST or the radioallergosorbent test. The intradermal test is less specific and is to be performed only if the skin prick test is negative. The third one is the nasal allergen challenge. Skin prick test is the most appropriate initial test and is usually the preferred option as it allows the patient to see the results directly. All the allergens that we saw earlier can be tested. Let us see how this test is done. A drop of standardized allergen is placed on the volar aspect of the forearm and then pricked into the skin using a lancet or a needle. As you can see, a number of allergens can be tested at the same time. Now, there should be a positive control with histamine and a negative control with saline, as we have to exclude false positive and false negative reaction tests. Now, after we do this, we wait for about 15 minutes, and at the end of 15 minutes, the wheel and flare reaction, that is the wheel diameter here, is measured. And by the mean wheel diameter, we take the averages of the maximum diameter and the diameter which is perpendicular to that. So these two diameters, this diameter and this diameter, the average of which is taken. And if the reaction is more than 2 millimeters in patients who are less than 5 years, and if it is more than 3 millimeters in older subjects, we consider the test to be positive. A positive skin prick test has to be supported by a relevant clinical history for the diagnosis of allergy to be made. What about this test? Rust. Let us see what happens. This is a specific IG estimation. The total IG estimation test is rarely helpful in uncomplicated allergic rhinitis, as 50% patients have IG in the normal range. So this is the one which is resorted to in most patients. So serum specific IG measurement has replaced the total IG measurement. Let us see what happens in rust. Serum is incubated in an allergen bound solid phase. IG in the serum with specificity to the allergen will remain on the solid phase, as you can see here. Now what we do is to add radio labeled anti-IG antibody. So this is added, which goes and meets this antigen and IG complex. Then what we do is to measure the radioactivity. The level of the radioactive signal is proportionate to the concentration of serum IG. So this specific IG, to which all these radio-labeled antibody, the detecting antibodies, are added, and then the measurement of the radioactivity which is produced is done. This helps to indirectly tell us what the serum specific IG level is. These RAST tests are more expensive. They take days to weeks for the results, and they are not more sensitive or specific than the skin prick test. The third one is the nasal allergen challenge. In this test, allergen is introduced directly into the nose in gradually increasing concentrations, and any reaction that happens is measured. Even though theoretically you can say that that's a gold standard for allergic diagnosis, it is time consuming. It requires extensive lab facilities and even proper resuscitation equipment and trained staff. So this is something which is almost never done. Coming to the treatment part, we can say that it's a three-pronged strategy. The first one is avoidance of the allergen. Second one is drug treatment or pharmacotherapy. And the third one, immunotherapy, which is adopted only in a very small percentage of patients. So our main focus will be on the allergen avoidance measures and the drug treatment of allergic rhinitis. It is not possible to avoid an allergen completely. Allergen avoidance measures are frequently expensive and impractical, but there are certain things that you can do to reduce your exposure. So, how do you reduce your exposure to different allergens? First one is pollen. So, what we can do is to keep windows closed at peak pollen times, that is early morning. Wear a mask over the nose and mouth to prevent inhalation of pollens. Dust mites, they live in bedding, mattresses, upholstered furniture, and carpets. So, if a patient comes to you with symptoms of allergic rhinitis, we can tell them to try to include all these avoidance measures in their treatment schedule. And most of the time, we have to advise them to combine these different allergy avoidance measures so that uh, any allergen which they are not really aware of can be avoided. So what can we do for these dust mites? You can put special dust proof or plastic covers on pillows and mattresses. You can ask these patients to use washable curtains. You can ask them to remove the carpets and replace it with washable rugs. For cockroaches, we have to tell them to eradicate cockroaches with the appropriate insecticidal bait. We have to ask them to keep their kitchens clean and wash the dishes promptly. Make sure that all food is stored in sealed containers. Seal the cracks in the floor and ceiling. And ask them not to store waste in their homes. Pets. If you have an allergy to animals, it's better that you avoid them. If you have a pet already and you cannot live without it, you should keep these pets outdoors or restrict it to a few rooms in the house. At the very least, you can keep it outside the bedroom. So, you advise these patients to wash their hands after petting, advise them to bathe their pets once a week to reduce dander, and ask them to vacuum carpets and mattresses regularly. These molds thrive in damp areas like basements, closets, bathrooms, and in places where fresh food is stored. And so you have to tell them to take care to clean the bathrooms and kitchens regularly and keep them well aerated. Allergy avoidance measures. Let us have a quick look into the drugs used in the treatment of allergic rhinitis. You know that there are different categories of drugs used in the treatment of allergic rhinitis. You got antihistamines, intranasal corticosteroid sprays, leukotriene inhibitors or leukotriene receptor antagonists, mast cell stabilizers, anticholinergics, and decongestants. Of all these drugs, antihistamines and topical intranasal corticosteroid sprays form the mainstay of treatment of allergic rhinitis. All the other drugs that we mentioned earlier should only be considered as a second line treatment. That is again for certain specific symptoms which might be more in certain patients. These medications aim to achieve improved symptom control and are not a cure for allergy. They need to be taken as long as there is allergen exposure causing symptoms. Let us look at the antihistamines now. Antihistamines are broadly classified into first generation and second generation. They form the first line of treatment in patients with mild allergic rhinitis. The older first generation antihistamines like phenyramine, chlorpheniramine, hydroxyzine, promethazine, and others are rarely used now because of the sedative effect caused by their propensity to cross the blood-brain barrier. Second generation antihistamines like cetirizine, loratadine, and fexofenadine are less sedating than the first generation ones. They are safe for long-term use and will give symptom relief on a once daily dosing. They give better symptomatic control when used regularly rather than on an as required basis. Levocetirizine and desloratadine, which are S isomers of cetirizine and loratadine respectively, are sometimes grouped under the heading of third generation antihistamines. Both have increased duration of action and have a positive effect on nasal airflow and help to reduce nasal congestion. Bilastin is the latest antihistamine to hit the Indian market. So what you have to do is to try to remember the dosage of the most commonly prescribed antihistamines like cetirizine, levocetirizine, fexofenadine, and bilastin. An easy way to remember is that cetirizine is 10 milligram, its derivative levocetirizine is 5 milligram. Loratadine is again 10 milligram, desloratadine is 5 milligram. Fexofenadine is 120 milligram, and bilastin is, as well as Avastin, they are 20 milligram tablets. All these are given once daily dosing, usually at bedtime. But bilastin is given uh, either half an hour before or after food because food interferes with the absorption. Bilastin can be given in the morning also. So less sedative drug can be given once daily in the morning, but sedative uh, drugs like cetirizine have to be given as a night dose. Remember that there are two topical intranasal antihistamines, azelastine and olapatadine. Uh, these drugs can be used to achieve rapid symptom control and can be combined with a topical nasal steroid. The common azelastine can be combined with an intranasal steroid spray, and you might achieve a better topical control with that. The main disadvantages of azelastine are the bitter taste and the requirement for twice daily dosing. Intranasal corticosteroids. Glucocorticoids are the most effective treatment for allergic rhinitis. Topical use in the form of spray is preferred over the systemic route because of the chance of side effects, especially in patients who have certain pre-existing conditions. These drugs reduce all symptoms of allergic rhinitis as well as the ocular symptoms. And as steroids have an effect on the pro-inflammatory mediators in the cell nucleus, their effect is slow to occur and is long-lasting. And most of these steroids will not have an appreciable effect on symptoms for several hours to days and can take 2 weeks for full benefit. So the practical application of this particular point is that when you start a patient on intranasal steroid sprays, you have to give an antihistamine along with that for a period of 1 week to 2 weeks so that the initial symptomatic period might also be tackled with the help of your antihistamines. The lowest systemic absorption and hence the bioavailability is seen with mometasone and fluticasone, and these can safely be given in children even 2 years old. Mometasone furoate and fluticasone furoate are the most commonly prescribed intranasal corticosteroids now. So the mometasone furoate as well as fluticasone furoate can safely be given in children about 2 years of age, and fluticasone propionate can be prescribed in children about 4 years. All of them can be given in the dose of 1 to 2 sprays per nasal cavity, once or twice a day, depending on the age of the patient. So these furoids are the most common intranasal steroid sprays given. Mometasone contains 50 micrograms per spray. Fluticasone furoate contains 27.5, and fluticasone propionate contains 50 micrograms per spray. What about leukotriene inhibitors or leukotriene receptor antagonists? These target potent inflammatory mediators by competitively blocking the binding of cysteine leukotrienes to the end organ receptors. So the binding of these leukotrienes is to the receptors are blocked by the leukotriene inhibitors. The most common or the most commonly used leukotriene inhibitor is montelukast. Montelukast in the dose of 10 mg per day is approved for the treatment of allergic rhinitis with asthma. You often find that levocetirizine or cetirizine are combined with montelukast, and this combination, the effectiveness has shown variable results. It might be effective in some patients, and some studies have shown there is apparently no benefit of combining these two. The next category of drugs is mast cell inhibitors. Cromolyn sodium or sodium chromoglycate is an agent that works by reducing calcium influx and thus reducing the degranulation of mast cells. However, if degranulation has already occurred, cromolyn sodium is theoretically not useful. Therefore, it should be used before exposure, which means it would be useful as a preventative agent. And it has to be used for 4 to 6 times per day since it has a short half-life. Anticholinergics, very rarely used. Ipratropium bromide is an antimuscarinic that can be applied topically in the form of a nasal spray. It helps selectively to decrease the secretory output of the different glands in the nose. The main symptom this drug alleviates is rhinorrhea. Again, 3 to 4 times per day, 2 sprays per nose, which is again probably much more commonly used than your anticholinergics and mast cell inhibitors. Decongestants. By its action on the alpha adrenergic receptors, decongestants can increase vasoconstriction and reduce nasal obstruction. This class of drugs is available in both the topical and the systemic forms. Topical means can be used as a nasal drops or nasal spray, like oxymetazoline and silometazolone are examples. And the systemic, phenylephrine and pseudoephedrine. Silometazolone is supposed to be better than oxymetazoline. Uh, they offer, these topical decongestants offer immediate relief from nasal congestion and obstruction, but take care not to use it for more than 1 week to 10 days continuously, because prolonged use, as we have seen earlier, can result in a rebound congestion and even a rhinitis medicamentosa. Systemic decongestants like phenylephrine are often prescribed in combination with antihistamines, but you should be careful while using that, especially in patients with hypertension, cardiac disease, cerebrovascular disease, and urinary retention because of its effects on the different receptors. And phenylephrine is a common decongestant which is used nowadays. If you have had a chance to look at the prescriptions of patients with allergic rhinitis, you might often find DC added to the name of an antihistamine. So antihistamine plus decongestant combination is a very frequent combination which is uh, used by the ENT people, and this DC stands for decongestant. And if you look at the prescription closely, if you look at the tablet closely, you might find that it is phenylephrine which is included as a decongestant in such patients. Systemic glucocorticoids, talking about oral steroids, they may be occasionally useful in patients with severe symptoms, and they help to reduce the mucosal swelling and subsequent use of topical medication also. This can again be used to cover a short period when symptom control is really bad. Only in severe patients, patients who do not really respond to your intranasal steroids or antihistamines or decongestants, we include systemic or the oral steroids in the prescription. Prednisolone 20 to 40 milligram is usually sufficient, and what we do is to taper it off over a period of 2 weeks to tide over the acute crisis. So here is a list of the drugs used in the treatment of allergic rhinitis, and what does the comparison show? We find that the oral steroids are the most potent of them, and you find they are most effective in all the symptoms like itching and sneezing, discharge, nasal block, and impaired smell. But as you have seen earlier, they are only very sparingly used because of their side effects. Intranasal steroid sprays come a close second with respect to their action on the different symptoms. You find that they are almost as potent as oral steroids in itching and sneezing, as well as nasal discharge, but less potent than that in nasal blockage and impaired smell. You also find that antihistamines are very useful in controlling sneezing and itching, and topical decongestants like oxy or silometazolone are very useful to relieve the nasal block associated with allergic rhinitis. So let us look how we proceed. So this is the practical application of what we have learned. We try to avoid the allergen by initiating certain measures, and then we start the patient on treatment also at the same time. We advise the patient regarding the allergen avoidance measures and start treatment. As we have said earlier, mild forms of allergic rhinitis with intermittent symptoms only, that forms the most mildest form of allergic rhinitis. So when such a patient comes to you for the first time with only a recent history of allergy, we start the patient on oral H1 blocker and antihistamine. Intranasal antihistamines are very rarely given in such patients. So we start the patient on oral antihistamines and we add a decongestant if the patient's main symptom is nasal block, or even a leukotriene receptor antagonist, especially if the patient's got asthma along with allergic rhinitis. In the moderate to severe intermittent allergic rhinitis or mild persistent allergic rhinitis, again we start the patient on oral antihistamines. But in such patients, we might have to add an intranasal corticosteroid also, because many of these patients who come to us will already be taking an antihistamine without much of effect. So we might have to add an intranasal steroid in such patients. And the other drugs that we mentioned earlier, like a nasal decongestant or even a systemic decongestant or a leukotriene receptor antagonist, might have to be added depending on the symptoms. So if it's persistent, you review the patient after 2 to 4 weeks. And if there is failure to control the symptoms, you might have to step up the dose of the intranasal steroid especially. We have seen earlier that the moderate to severe form is the most severe of all the different types of allergic rhinitis. And when such patients come to us, they've got severe symptoms, their daily activities, their school, their work, or their leisure activities, all these might be impaired. You start the patient directly on intranasal corticosteroids. And as I was telling you earlier, especially during the first few days, you have to give an antihistamine also, and then we can stop the antihistamine and see how the patient responds just to the nasal steroid. You might have to add a LTR, the leukotriene receptor antagonist also. Again, as in the other category of patients, you review the patient after 2 to 4 weeks. It's improved, you can step down and continue treatment for 1 month and stop. But if there is failure, you have to review the diagnosis, review the compliance. You might have to increase the dose of intranasal steroids, ipratropium, very rarely added. Blockage, you've already added decongestants. And here comes the role of your oral corticosteroids. Moderate to severe allergic rhinitis doesn't have much response to intranasal steroid sprays and antihistamines. Short course of oral steroids is recommended here. Okay, this is how you proceed. So mild form, only oral antihistamine. A moderate to severe intermittent or a mild persistent allergic rhinitis, you might have to add intranasal corticosteroid sprays also. And again, decongestants and leukotriene inhibitors might also have to be prescribed along with these. And if it's a moderate to severe form of persistent allergic rhinitis, intranasal steroids definitely. Add the other drugs that we mentioned earlier. And for a short course, if the symptoms are not getting controlled with these measures, you might have to think of adding an oral steroid also. Coming to the last part of our lecture here, immunotherapy. Allergen immunotherapy is resorted to only in a very small percentage of individuals. Let us see what it is. Allergen immunotherapy involves the repeated administration of an allergen extract in order to induce a state of immunological tolerance, thus helping to reduce the clinical symptoms and also the requirements for other medication. So what does it do? It helps in blunting the seasonal increase in allergen-specific IgE. It increases the blocking IgG antibodies. Let us see what the different types of immunotherapy are and how they are administered. So allergen immunotherapy is indicated only in patients whose IgE sensitivity is confirmed either by doing a skin prick test, you have to get a positive result, or you might get an increase in the serum allergen specific immunoglobulin E. So that is the first criterion to be fulfilled. The second one is that the symptoms are so severe and they fail to respond adequately to usual treatment with antihistamines and steroids. So it is highly effective, but it's restricted. Treatment is restricted to patients with severe disease, the limited spectrum of allergies, and again those who fail to respond to your usual treatment adequately. There are two types of administration. One is the subcutaneous SCIT, and the second one is SLIT, or the sublingual form of therapy. In the subcutaneous type, there are two phases. You give weekly injections for 8 to 16 weeks. That is, with each week, you increase the dose of the allergen extract gradually. And we have reached 16 weeks. After that, you have to give maintenance injection at 4 to 8 week intervals. So initially, there is an updosing phase in which you increase the dose of the injections. And after 16 weeks or 4 months, what we do is to give the injections as maintenance injections at 4 to 8 weekly intervals. That is 1 to 2 month intervals. You give the injection, and this treatment has to be continued for a period of 3 to 5 years. Whereas SLIT is a sublingual route, either drops or tablets, and the efficacy is similar to that of SCIT or SCIT. So you have to remember that this is a treatment which is highly effective in selected patients only. The take-home messages: cure is rarely possible. Avoidance, you can't say it's the best treatment. It might not be practical in all patients, but still, that is one thing that you can definitely try out. Drug therapy may be lifelong. You might have to continue the drugs lifelong in patients with severe forms. And again, you have to try to limit the medicines to the minimum and give regular medications so that morbidity and associated complications are reduced. And I was telling you earlier that immunotherapy can be tried in a select few percentage of patients with allergic rhinitis. That's today's session. Thank you very much. Try to stay safe and healthy. Hope to see you soon. Bye.